So, principles of MSK history and examination. So, musculoskeletal disorders are often multi-systems that require a wide range of questioning, especially within the history. So, we need to be looking at the history of presenting complaint. Presentations may be acute and obvious, such as a fractured bone after a fall, or potentially more chronic, extending over months and years. It's important to be patient when we're doing these consultations, and it's also important to ask what functional, psychological impact these MSK pathologies and diseases have on our patient. So things to consider when we're looking at history presenting complaint: timing of onset. Is it acute? Is it subacute? Is it chronic? Looking at the pattern of the symptoms. Is it a single joint? Is it multiple joints? Looking at the history of the injury. Was there any trauma? Was there any, was it a trivial injury? Someone picked something up off the floor and done their back in? And also looking at associated symptoms, things like fevers, rashes, weight loss, bowel symptoms, more your red flaggy type things. So when we're looking at the key symptoms of MSK, there's a few we want to pay attention to. Things like joint pain, joint swelling, joint stiffness, muscle pain, weakness and loss of function, and possible locking or triggering of any of the joints, and also looking at deformity. When we're looking at joint pain, is there any particular mnemonic people like to use, or anything to help them nail down a history of joint pain or muscle pain? Yeah, perfect. Thanks, Joanna. Socrates. So we use Socrates quite often. We look at the site, what joints are affected, the onset, when did the pain start, character of the pain as well. Is it a severe pain? Is it a deep pain? Or is it pain on movement, radiation? Is there any referred pain? Associated symptoms. So looking at features of any inflammatory arthropathy or any systemic disorders, looking at fevers, night sweats, etc. Timing. So when is the pain better? When is it worse? Is it worse at the end of the day? So considering osteoarthritis, exacerbating and relieving factors. So what makes pain worse? What makes it better? And having a look at the severity as well. So then moving on to things like joint swelling. So swelling can be suggestive of, say, an effusion caused by underlying disease. It may be difficult to differentiate from, say, an inflamed bursa, for instance. But as we go through the presentation, we can consider a few scenarios where we can differentiate between the two. Again, looking at joint stiffness, limited range of movement or difficult to use, and then looking at what's causing that. We then move on to the past medical history. So asking specific questions about any history of arthritis will help us differentiate between osteo and rheumatoid arthritis, asking about any pre-existing MSK diseases, and having a look at the age of diagnosis, treatment for the condition, any complications, and having a look at last follow-up and any recommendations if someone's had I don't know, say plantar fasciitis in the past. It's very likely to repeat again later on in life. So it's important to know what's worked for that patient in the past. Looking at the drug history. So patients with musculoskeletal disorders commonly take NSAIDs or can have corticosteroids, such as injections. We need to make sure we're taking a comprehensive drug history, looking at things that are prescribed, over-the-counter medications and herbal remedies also, as certain medications could be useful, but certain medications can also hinder recovery and also cause certain MSK pathologies, which we'll go through later. So looking at the family history, is there any history of autoimmune disease in the family or inflammatory arthritis? Social history, looking at how they function on a day-to-day, having a look to see how they are with their washing, their dressing, can they get out, how to get on with their daily activities, and then finally looking at ice. So what ideas does the patient have? What do they think could be going on? What's worrying them at the moment? And is there anything that they might be hoping for in the consultation? And red flags, like we mentioned before. So moving on from that, we look at examination. So for most MSK examinations, the general is look, feel, move approach. We can then consider certain special tests for certain conditions. We can have a look at the neurovascular status. We can compare left and right if it's a joint such as the shoulder. We look and we compare from what might be normal and what might be injured or show signs of pathology. And it was always important to examine the joint above and below, because what can happen is, say you have a foot pathology, say someone has a fallen arch in their foot, this could potentially mean further up the chain they have a gluteal weakness, which affects the biomechanics further down the leg. And if it's a weight-bearing joint, it's also important to consider looking at the gait analysis as well. So we'll start and we'll move on to the cervical spine. So as we can see, here we have the cervical spine. It comprises of 7 vertebrae, so vertebral bodies. And what we have here is, in the vertebral bodies, we have spinous process, which is at the back here. And we have transverse processes as well, which are on the side. So these spinous process and transverse process are very important in maintaining the rigidity of the spine, and also they serve for multiple attachment points for ligaments, muscles, structures that can be very important to understand when it comes to certain pathologies. So an interesting fact about the C2, there is a tiny protruding process that comes up from C2 which attaches into C1. Now, this process here can be quite important if you have a patient that comes in and says they feel they have to hold the head up. Now, this is typical of a DIP fracture or a DIP fracture. So this is a medical emergency. These people need to go into A&E as soon as possible, and they will likely be MRI'd and braced at the neck. So moving on to the muscles. So with the muscles of the neck, we've got a few important ones. So we've got the scalenes at the front and the side, which rotate and flex the neck. We've got sternocleidomastoid, that's involved in rotation and lateral flexion, and the trapezius at the back. This is a muscle that's commonly injured when it comes to things like whiplash disorder. So the trapezius extends the neck and it stabilizes the scapula as well. So we have movements of the neck. So we have flexion, extension, rotation to the left and right, and also lateral flexion to the left and right. So moving on to whiplash disorder. So with whiplash disorder, it's a sudden hyperextension and hyperflexion injury to the neck, generally caused by a sudden acceleration, deceleration mechanism of energy transfer of the neck, a whip-like movement. So whiplash generally affects 300 persons per 100,000 attending in A&E every year, and there are approx approximately 1,500 whiplash claims a day, costing insurance companies a whopping 2 billion a year, according to the Association of British Insurers. So within whiplash disorders, typical features that we might see are neck pain, reduced range of movement, local and general neurological issues. So maybe they might have some numbness down the arm, etc. But you may also have psychological issues such as trauma, PTSD as well. So there's a Quebec Task Force classification for the grades of whiplash disorder. So 0, no complaints or physical signs. 1, neck complaints but no physical signs. So these patients might just have some pain. 2, neck complaints and musculoskeletal signs. So they might have some neck pain, but they may also have spasm in the muscles we spoke about a little earlier, so such as the sternocleidomastoid or the trapezius muscles at the back. Neck complaints and neurological signs, they may complain of headaches, they may complain of pain down the arm. And then the 4th grade, which is the most severe, neck complaints with, say, a fracture or a dislocation. So someone I've treated in the past has come in with whiplash disorder. Now, they had some damage to their ligamentum flavum, which is the small ligament between each of the vertebrae. Now, for this patient, you can imagine if the ligament's quite deep, it can be quite painful, and ligaments tend to be quite avascular structures. So we could imagine if there's not much blood flow getting to that area, it can be very difficult to treat and very difficult to heal as well. So these patients need bracing, they need a lot of support, a lot of encouragement, a lot of physiotherapy as well. Investigations we might consider for whiplash. We may have an X-ray to exclude a fracture, as these can be quite common. And of course, CT and MRI scans for patients who suffer from chronic pain, or patients who, say, have pins and needles, paresthesia down both arms, pain down both arms, reduced feeling, headaches, things like blurred vision, double vision, dizziness, etc., to rule out any sinister pathologies. So general management then, what do we do for these patients? So the general management advice would be to work within pain-free limits. Early intervention is key. There's always a high initial pain intensity or high frequency in healthcare utilization in the first weeks after the injury. There's also a positive correlation between post-traumatic stress and the outcomes. So it's also really important to consider providing the patient with extra support in terms of their mental health. Do they need CBT, etc.? So with these patients, what we need to look at is looking at their range of movement, having a referral to physiotherapy to aid with their range of movement and their pain. It's also going to be quite important to consider pain relief and perhaps some muscle relaxants to aid the patients with their muscle spasm, as this can be quite debilitating. It's said at least 40% of people will have some resolution by 6 weeks with therapy and pain management. Approximately 50% of people make a full recovery within 6 months. The risk of chronic pain developing after whiplash injury typically estimates around 20 to 40%. So it's important to take care of these patients. Something that can really help with these patients, which I find, and it's something that people can advise in a primary care setting or a secondary care setting, is deep neck flex exercises. So the research shows that muscle relaxed, so We've got an unknown user. Sorry, your name's not coming up there. Who's
Charlene.
Charlene, thanks for your question. So muscle relaxants can be used pretty much straight away to help the muscle relax to aid the spasm and things like that. Typically, when it comes to NSAIDs, we like to leave it maybe 48 hours after the injury to allow the initial inflammatory process to take effect. I hope that answers your question. You're welcome. So moving on to the spine and lumbar back. So bony structures in the lower back, we've got your vertebrae, we've got L1 to L5, and then we've got S1 to S5 as well. But we'll typically focus today on the lumbar region. Okay, so can anyone tell me what are the movements of the lower spine, the lumbar spine? What typical movements are we going to look at and assess? Joanna, yes, I do have a website. We'll go through that soon. Thank you for that. That's quite useful. Tara, extension, flexion, very good. Yep, perfect. Extension and flexion. One to add, we also have lateral flexion as well. So bringing the body down to the side. Okay. So muscles we need to consider when we're looking at back. So erector spinae. So the erector spinae, the iliocostalis, the multifidus muscle. These are very deep muscles and they generally focus on the extension of the back. The general flexion of the lumbar spine happens with the abdominal muscles at the front, and we've got the obliques as well at the sides, which will help laterally flex the spine too. So you're all wondering now why there's a picture of a fish. Can anyone tell me what this might relate to? So we're looking at the history of low back pain. Tuna fish, well done, Ruth. Tuna fish is the one. So what does tuna fish stand for? So T stands for trauma. U stands for unexplained weight loss. N stands for any neurological symptoms. So bilateral weakness or numbness in the legs, bilateral pain, age, so over 50, F for fever, I for intravenous drug use, S for steroid use, and H for history of cancer. So this is a very good tool you can use with any of your back patients to consider a sinister pathology. So this acronym will help us differentiate between things like, say, spinal fractures, metastasizing cancers, and spinal infections, just to name a few. So, I mean, I don't know how many of you can relate to this image, but I can, especially since I've now hit my 30s. It could be as simple as picking up a pen off the floor, and that gives you the pain. So MSK is low back pathologies, such as typical back pain, is the most common primary care MSK presentation. Generally will affect 80% of the population in their lifetime, and it's the largest single cause of lost working hours in the UK. Typically, lower back pain can resolve within 6 weeks. So what do we see? We see a localized pain or a band of pain across the lower back. Typical back pain should not have any radiation into the lower extremities. They can present with tenderness or spasm, severe back stiffness, inability to kind of stand up or get up from a laid position, sudden onset of back pain, especially with heavy lifting, activities or a quick change in movement, typically when flexed or rotated. Okay, now when we're looking at advice that we can give to our patients, the NHS advice leaflet for back pain has got a really good website. It's good material out there. It's a good poster. If you type in back pain NHS, it will be the first link that comes up. I have tried to copy and paste a link into this presentation, but it just comes up as back pain NHS. So hopefully Camille might be able to pop that into the chat. So demographics then, typically people affected all ages, but the research shows between 40 and 50 years old. So management advice, we look at what is that? No. Sorry about this, guys. We look at pain control and advice. The single negative thing someone can do with back pain is not move. So we encourage all our patients to complete gentle exercises such as knee rolls, knee hugs, things like that to start getting the muscles and the joints working. Physiotherapy can include manual therapy, and Pilates can be a big help for patients with lower back pain. Typically, the spasm and the injury, it may extend from a foundational weakness in the core muscles. So Pilates has shown to help low back pain and prevent low back pain as well. Investigations, what would we consider? Lumbar x-ray, MRI scans for anyone presenting with chronic pain or neurological symptoms, and blood tests can be useful as well for anyone showing any systemic features such as fevers. Let's go back. So sciatica, we'll move on to sciatica next. Can anyone tell me some causes of sciatica? So what causes sciatica? Nerve compression. Good. Thanks, Sonia. Pregnancy. Yeah. Pregnancy is good. Okay, so stenosis, disc protrusion, brilliant. So sciatica is pain involving the sciatic nerve, which typically gives pain and neurological symptoms deep into the buttock and down the leg. That is usually unilaterally. So the common signs or the common causes of sciatica, as you guys have mentioned, herniated disc or a bulging disc in the spine. You can have overgrowth of the bone, so Burney spurs, which can put some compression on the nerve root. You also have spinal stenosis, which is narrowing of the spinal canal. We have spondylolisthesis, which is one vertebrae slipping forward and causing some compression of the spine or the nerve root. Pregnancy, I think Halima's mentioned pregnancy. Thank you for that. Pregnancy, yes. So when a woman becomes pregnant with the hormone release, this actually makes the ligaments more lax, the muscles more lax, which reduces the strength and the stability of the joints, and this can put more pressure on the sciatic nerve. And piriformis syndrome as well. Piriformis syndrome, sciatic nerve innervates a piriformis muscle, and if this muscle gets tight, it puts pressure on that sciatic nerve, giving you them uncomfortable symptoms down the back of the leg. So, like we mentioned, the presenting features: deep pain in the buttock, with or without pins and needles, numbness, and it's usually unilateral. Things we want to consider: typically we won't be imaging these people straight away. We may give them a course of physiotherapy But if this does not improve symptoms or the neurological symptoms get worse, we may consider completing, say, X-rays, MRI scans. So management of these symptoms, so self-help, self-help measures are very important. We need to encourage the patients to stay active, resume normal activities as much as they can, and also return to work. Prolonged bed rest is not recommended. We want to advise that they apply local heat to the area. This can help relax the muscles, and we want to make sure that they're having positive chats with work so that they can make adjustments. Are they sat on a desk on an uncomfortable chair for hours on end? Do they need some support from occupational health? And we also want to advise our patients to exercise regularly to make sure that we're keeping the joints nice and supple. So we're moving on to cauda equina syndrome. So this is a medical emergency, obviously, and I just thought it was important for us to cover. This is something I've seen quite often in the ED department, and it's something that's quite serious and can have serious complications for our patients. So presenting features of cauda equina, so unilateral or bilateral radicular plane, especially if it progresses from unilateral to bilateral with or without sensation loss, loss of reflexes, and myotomal weaknesses. We can also have altered saddle sensation. So this can be assessed with light touch or pinprick. Bladder disturbances are quite common. This can be an increased frequency or an incontinence. You may also have patients present with bladder retention and also bowel disturbances, so loss of anal tone or sphincter tone. Sexual dysfunction can also be a presenting feature. So with these patients, past medical history, we look at things, so people who come in with, females that come in with PID, pelvic inflammatory disease, stenosis, like we've mentioned before, and or previous spinal surgery. Generally, cauda equina will affect people over the age of 50. Has anyone had any experience dealing with people with cauda equina? Yes, prostate cancer too, definitely is one. So someone comes into your clinic or comes to A&E and they've got sensation loss down both legs, loss of reflexes, weakness in both legs, and they have urinary incontinence. What are we doing with these people? Perfect. Thank you, Claire. Thank you, Karen. We would bladder scan, yet we could also bladder scan them. What we want to focus on is we want to focus on getting these patients MRI'd within 24 hours through ED or a local pathway, and we want to refer them to neurosurgery as soon as we can for assessment. If the MRI shows cauda equina, then this is a medical emergency and they need to be sent to the nearest neurosurgery centre to consider their options. Generally, these patients that come in could be suffering with the symptoms for a while, but what we see in ED is people with chronic low back pain with a slip disc or a herniation that may just then progress further, and they would attend to see the GP or the ED service.